just trying to.
Okay, good morning, everybody. It's 10 o'clock. Welcome to the Health Scrutiny meeting, Commission meeting, on this lovely crisp winter morning, which also is being broadcast. So, please can I accept the minutes of the last meeting as a true and correct record? Okay, thank you. And Sarah, do we have any apologies, please?
Okay, so I've got Councillor Michelle Welsh for other reasons, substituted by Councillor Paul Henshaw, Councillor Megan McGrath for medical reasons, substituted by Councillor Errol Henry, Councillor David Martin, other reasons, Councillor John Wilmot, illness.
Thank you. So, can I welcome Councillor Henshaw and Councillor Henry to this meeting? Oh, Councillor Dudley.
Sorry, Councillor Jackson, you rushed through the approval without going through the pages of the previous meeting for the minutes, and I had a few little corrections for you.
Oh, okay. Right. Okay, well, we'll come back to that in a minute. So, presumably, Councillor Martin and Councillor Wilmot have got these substitutions? No. Okay, thank you. Yes, Councillor Dudley.
Page 12, it says regarding 100 million permitted overspend, there was a time frame permitted due to the funds being approved. There was no fun about it. I think it meant to be funds. Further down it said questions were raised about the number of patients referred to the Queen's Medical Centre Neurology Department. There was no question about the number of patients being referred. It was a question about the number of patients actually being seen after they were referred, which is a distinctly different thing. Does that make sense to you, Catherine? It wasn't about the number of people referred. It was about the number of people being seen after they were referred. That was the whole point. Thank you.
Thank you very much for that. Has anybody got any declarations of interest? Does any member present have disclosure pecuniary interest to declare? Or as a private interest? Councillor Eddy.
Just to say that I'm Vice Chair of the ICP, appointed Governor at Sherwood Forest Hospital Trust and Gloucestershire Healthcare Trust.
Thank you for that. Councillor Dudley.
And I'll just declare an interest in the fertility policy as I regularly refer into that service.
Okay, thank you. Right, Nottinghamshire ICB review of fertility policy. I would like to welcome representatives from the ICB here this morning. Alex Bell, Director of Communications and Engagement. Victoria McGregor Riley, welcome, Acting Director of Strategy and Systems Development. And Dr. David Briggs, Medical Director. Would you please like to present your report, please? Thank you.
I'll start if that's okay. Hello everybody. We'd like to invite a conversation with you about a proposed listening exercise around fertility. As colleagues will be aware, when we came together to formulate the ICB from the former Nottinghamshire CCGs and Bassetlaw CCG and develop the one organisation, we were required to align our policies so that there was equality of provision across our entire population, for which we have the responsibility for commissioning services. A significant amount of work has been undertaken to review those policies where there was any differential, and also to support alignment. In the vast majority of those cases, that alignment was undertaken with very minimal change in what was already provided to the wider population. However, there is one policy which we feel we would like to more actively listen to the voices of our community and with wider stakeholders to understand how we should progress in terms of defining a final policy, and that is in respect to fertility. So this is the start of that, very early start of that conversation. I'm now going to introduce my colleague Dave Briggs, who's going to go into a little bit more detail about what the policy is currently offering to people and what the proposed changes may be and upon which we'd like to listen more from our wider community. Thank you.
Hi, thank you, Chair. So this particular policy refers to a number of different treatments that are available on NHS to improve the opportunities or abilities for people to get pregnant. The policies across the East Midlands have been quite different in some cases, and not only do we think it's important to have a single access policy or equal opportunity for Nottinghamshire, it's also important to us that that is true across the whole of the East Midlands. So we are working together across East Midlands on this policy. The policy also needs to take into account other groups that previous policies that weren't considered, and I'll come on to the different elements of the proposal in the next slide, if I may. Okay, so this is a summary of the proposed changes to the fertility policy. So the first is that for the first time, single women and transgender men will be offered treatment should they fulfill the rest of the criteria. Same-sex couples and single women will have equitable access as heterosexual couples. Differences in access around things like smoking, weight, and other factors will all be unified across the East Midlands. Some slight changes, but not huge. Anyone wishing to become pregnant must not have a living child. That's not a change, that's still in the current policy, but we thought it was important to highlight here. There will be no provision for NHS funded fertility treatment for those who have undergone a sterilisation process. There will be offering of one offer of IVF as part of this policy across the East Midlands as a proposal. There will be 3 cycles of intrauterine insemination as part of this policy, and we've also got a policy around the storage of the products for conception or gametes across the East Midlands. I've got to say the changes in that aren't particularly big, quite similar, but it's important that there's consistency across the East Midlands on that. So 2 big changes, or 2 changes in the proposals. One is 1 cycle of IVF, or intra vitro fertilisation, or test tube fertilisation, and incorporation of other groups who previously weren't considered as part of the existing policies. Okay, thank you.
Thank you, Dr. Briggs. So hopefully that's a useful overview of what the proposed policy is, but we appreciate there's quite a bit of detail and some new acronyms and so on that people might want to unpack in a bit, which we're more than happy to do. But I'm just going to talk briefly about how we are listening to our population and stakeholders, because this is an important policy and there are some changes being proposed. So we want to make sure we're really hearing from people to check that we've got this right. So in the last 10 days or so, we've gone live with this period of listening, this period of engagement, and that will run through until the 10th of January. So it's about 60 days, a couple of months. We really kind of want to invest some time in this, particularly over the sort of busy Christmas period, to give people a real chance to digest this, think about it, and give us their feedback. There's two kind of broad questions, really. We're really keen to hear from people what they think about the proposals and how that might impact on them or people of kind of similar population that they might belong to. And we're most keen to hear from citizens who live in Bassetlaw, because there's a slightly kind of more impactful change being proposed there. We want to also hear from single women, same-sex female couples and trans men. But we are keen, whilst those are our kind of priority groups to hear from, we're keen to hear from anyone who lives in Nottingham and Nottinghamshire, and colleagues from the other integrated care boards across the East Midlands will be doing the same to hear from their population. So across that whole East Midlands patch, we will therefore hopefully have a really rich set of feedback and responses to these proposals. So in order to do that, we're going to use a range of different kind of methods to hear from people. We will, of course, offer, as we always do, translated and accessible and kind of different formats of all this information. And as we go through this process over the next couple of months, we're going to be quite carefully monitoring the data that we get back to check to see if we're hearing from all of the groups that might be impacted by this policy. And if we're hearing, for instance, less than we might want from any particular group, then we'll make sure we focus our efforts to hear from them. We'll be using lots of different methods, virtual conversations, online surveys. We'll offer people the opportunity to meet one-to-one or with individual community groups, should they wish. And also, we'll be holding 3 sort of public events to hear from people, noting that the people who are impacted by this policy change are of working age. We are holding these in the evening and at the weekend, very deliberately, to give that maximum opportunity to hear from people. But broadly, our approach really is to kind of, particularly when thinking about potentially underserved or marginalised communities, we've made proactive contact with lots and lots of groups that we're aware of, offering them the opportunity to meet with a clinical colleague, to talk to them kind of on their terms, in their meetings, in their communities, rather than expecting people to come to us. All of that data that we'll hear from that through the survey, through discussions, through feedback, we'll thematically analyse that, and you'll see that at the end of this process. As you've seen many times before, there'll be a report that draws out the key themes and the recommendations and the kind of summary of the feedback to help us consider that. And to stress again, this is a proposal. We have not made a decision. This is about listening to potentially impacted populations. So final slide, please, Catherine. Again, this is a proposal. We're listening. Part of our listening is to hear from you directly here today. There are some questions in the paper that we've submitted that I know you've got. They're also on the slide here. We're keen to hear from you today, both on what you think of the sort of substance of the proposed policy here, but also how you might help us to reach communities and populations who might be impacted, who are in your individual divisions or areas that you're aware of. And that's it. Thank you very much, Chair.
Thank you, Alex, Victoria, and Dave, for your presentation. Thank you. And it's nice to see that you are engaging with everybody about this, and also allowing other people to engage in the IVF as well, which is good to hear. But currently, you go on NICE guidelines with your policy, and NICE bring out more guidelines this spring. So why is the rush to do this through now, and not wait for new guidelines to come out? I'll just ask that before I open it up to the question, because it seems to be rushing it through when you've got NICE bringing more guidelines out, and probably it might be different to what you have all your policy which you're trying to set now. So I just wonder why you're waiting. But I'll open up the questions now, and then you can answer them all together. Bethan and John. Bethan, please.
Thank you. I absolutely believe there should be equity across the board for everyone being able to access the provision. I've got a couple of concerns and questions. So the first one is, how do we consult the women who will be affected by this? Because you don't know you're going to need the fertility help until you need the fertility help. So that's my first. How are we going to miss a huge group of people who don't necessarily think this fits in with them now? So that's one of my first questions. The second part is, in Basset Law, for example, where it's higher now, is there a waiting list on the people who are waiting for the fertility services? And if so, if it was to change, when will it change? And will those people who, if there is a waiting list, have the 3 options, or will it go down to 1? I think I'm trying to work out the logistics of when it would change, how it would change those people who are already in the system. But totally agree with equity, but I just don't know if there's a more needs to be done around, if you're reducing it in Basset Law so much, the conversations you have with the people. I don't know how you have those conversations with people who might not even know they need the fertility treatment, if that makes sense.
Councillor Lee.
Thank you, Chairman. Lots of questions. Where do I start? So 4 years ago, you came to District Council, where I'm a member at, and you asked us about our opinion on reducing it down to 1 from 3. And I said the same thing then. I'm going to say no. Why are you racing to the bottom? Because you are racing to the bottom. If you, what you are saying is, well, other areas have got 1, so we're going to go 1. You don't know you need IVF until you need IVF. So the question is you're asking the members of the public something that most of them don't think they'll ever need. So you're going to get the response that you want to get, and that is, let's cut the service because it saves us money. And that's what you are doing, and that's what you did last time. There's a national question that is always asked about national defence, and they always put out there is, where would you save money if you wanted to save money? And everybody says, let's cut defence. The people that don't say let's cut defence are the people that understand defence. And that's the same question now. If you were to ask people that use IVF, should we cut funding in IVF? They would say no. You ask anybody else that doesn't use IVF, they're going to say yes. So you shouldn't be asking us what we think. You should be asking the people that have had IVF, do you think we should cut IVF? And most of them, if not all of them, I would say would probably say, no, you should not be cutting IVF. Don't speak to people that this doesn't affect, because you'll get the answer that you want, and that is, let's cut IVF. And we all know that's what you're going to do. You did it 4 years ago, and you'll do it now. The question that I have is what, so if I don't use the proper terminology, I apologise, because I don't understand the terminology, so I apologise. On the first series you have, what is the percentage take for women to get pregnant, or people to get pregnant, and then what is the percentage of the second, and then what is the percentage of the third? And the reason I ask is if you are getting rid of the second and third chance, is then people aren't going to get pregnant. Most people can't afford private IVF. I know, because my family went through IVF and sadly it didn't work for them. They could afford 2 private sessions but couldn't afford after that because it's very, very expensive. They're the questions. Depending on the answers, Chairman, I may come back later if that's okay.
Thank you. I've got lots of people asking questions. Do you want to answer one of these now, or do you want to wait to the end?
I think there's quite a lot packed in there already, so I think it would be good to pick up some of those.
Okay.
Victoria, do you want to kick us off?
Yeah, I'm not going to answer any of the clinical conversations. I'm going to leave that today, if that's all right. But I'll try and address some of the others, and then other colleagues will come in. So why now is very much about, we're working as a collaborative across the East Midlands, and there is a general consensus that we do need to move to an aligned policy that's fair and equitable as much as possible, as quickly as possible. It's actually a duty on us as an ICB that we do provide a single policy for our communities. So we're trying to meet that obligation that we do have. So that's why we want to do this with some degree of pace, because we've already been in existence for quite a while. So we wouldn't see it as rushing towards, we would see it as we've really tried to work collaboratively to get to where we are now. In terms of the consultation and engagement, I absolutely do accept the point about the fact that we need to be as broad ranging and encouraging everybody to participate in this listening exercise, and that is what we're trying to do. We're trying to be as broad as we can in broadcasting the opportunity to work with us and engage and offer views as much as we can, and we are actively seeking the views of those people that we think may be most impacted by the change. That will obviously include and be an offer open to people who've already received IVF, as well as people who may potentially need it in the future. So we are really opening this up as an opportunity. We're not coming here seeing this as the only forum or the only platform to have this conversation. We are really actively seeking your support to make sure that this opportunity is open to all our communities and our population, so that they can engage in the conversation with us. I'm going to pass on to Dave in terms of some of the more clinical conversations, if that's okay.
Okay, so success rates. Success rates for IVF. Okay, very age dependent. So when people quote figures, if you look them up, they'll range quite dramatically depending on what age group they're looking at. If you are looking at those under 40 and include all age groups, it's around 30% on the first cycle of people get pregnant, and then it's just over 30% for those under 40. If you look at the groups from under 30, it's about half get pregnant. That diminishes for the second cycle, I've not got all the figures to hand on that, and diminishes even further for the third cycle. To get over 60% success rate in the all age groups up to 40, 6 cycles are required, with them diminishing each time. So that's the information. The group looking at the guidelines considered the success rates as part of their proposals, of which I wasn't part.
Thank you for that. Councillor Henry.
Thank you, Chair. I want to pick up on a point you made, Dr. Briggs, about, well, I'll go back. It's on page 20, paragraph 2, bullet point 6, and it talks about the person wishing to become pregnant and or their partners must not have a living child from a previous relationship or current relationship. What is the rationale behind this? And it seems to me that you sort of ignore the emotional element of the process that couples go through when they're going through IVF.
So the access criteria, or the ability for people to access the service, is the presence of a living child is around how we can use the money we have available to treat infertility in the fairest way. I agree and understand that doesn't diminish the emotional impact for those who have a living child and want more children, have a living child, and have a new relationship and want a new family with that relationship. I accept it and understand that is a significant emotional and psychological problem for them and would never want to diminish that. However, we do have to look about how we can offer the most equitable access to treatment for the money we have for intra-vitro fertilization services. And that's why it's really important that we have this listening exercise so we can pick up what our citizens are saying are the most important elements of it.
Thank you. Councillor Bailey.
Thank you, Chairman. I suspect my position on this is quite far away from your policy paper. So, for the start, the NICE recommendation is 3 cycles. We're going down to 1. I say down because Bassett Law is getting downgraded. We're going to be getting a worse service, and that is something the RCB promised would not happen when Bassett Law joined the RCB. So I find it an absolute shame, and I will hesitate to word betrayal, because instead of upgrading the rest of Nottinghamshire to be in line with the NICE guidelines, to be in line with Bassett Law, I believe the case of change had the 8 options, with 8 being the most restrictive and 1 being the NICE recommendations. Bassett Law sat at 2, and we're proposing going down to the 7th most restrictive. So not only are we being downgraded in terms of Bassett Law, Nottinghamshire is being beaten by 11 other ICBs. So I do regard it as quite a shame. And to the fact that women are having children later in the UK. Fertility is that big issue. I think making it more difficult is not the approach that we should be taking. I don't think it's the approach you want to be taking. And I accept the arguments about funding, but I don't think this is the way to go about it. I don't think we should be. I think Councillor Lee made the point where this seems to be the cost-saving measure. Other ICBs managed to find the money for more cycles. I definitely think that you guys should be looking at that with a bit more. I definitely should be looking back at the drawing board on it, to be honest, because I don't understand how other ICBs can do it and we're not. So in terms of support and the item to discuss, don't support it. I don't think Bassett Law residents will support it. I'm always sceptical about consultations that go through Christmas around this period. I don't have a good experience with people doing consultations around November, January time. It does seem to be drowned out a bit. So, I do think my position on this is far away from what your paper is. I do accept that this is not a proposal. This is not the proposal that is open for consultation. But I think my position that we should be expanding access, we should be following the guidelines, is not one that is accepted across the East Midlands ICBs. So I just have to put on record, I don't support this. I think it's an absolute shame that Basildon is getting downgraded. I can't ever support that. And I think arguing for the sake of equality and alignment, well, the equality and alignment that's happening is just Basildon's going far away. It's getting downgraded. So I think we should be looking to upgrade our services and using the NICE model as an example to strive for, not as an example to race to the bottom. Thank you, Chair.
Thank you, Councillor Bailey. Would you respond to that?
Yeah, thank you. Really do appreciate feedback, and absolutely recognise that this is a very tricky subject to discuss, and there's lots of emotions and lots of implications. So I really do appreciate the feedback. Just to reiterate, this is again a listening exercise. It is not formal public consultation, so that needs to be considered into the future. This will help shape the policy or the proposals that we may wish to put forward in the future, and all views will be considered as part of that. So please rest assured. I do absolutely understand the point that you make about when Basildon became part of the broader church of the ICB and into the Nottinghamshire area. There was very much a feeling that we wanted to make sure that we retained the level of policies and the level of commitment that we did. But I will point to the fact that we are in significantly different financial considerations now than we were, 3 years ago when those kinds of decisions or those offers were made. But equally, this is not a policy driven by financial need per se, because actually what we will be doing by opening up to be more fair and equitable across a broader range of our community, it actually may have other implications for the funding that we do provide for this, which is why everything we do needs to be seen to be fair and open, and we need to be seen to be providing the best possible care that we can for all our community with the money that we've got available. But just taking your points on board, absolutely understand and absolutely welcome them. Thank you. And I would encourage you to go back and offer the opportunity for Basildon people to also engage in the listening exercise.
Thank you for that. At this point, I'll just bring in Sarah Collins and welcome you to this committee, Sarah.
Thank you very much, Chair. Yes, hello, I'm Sarah Collis from Health Watch Nottingham, Nottinghamshire. I'm interested about the methodology of the listening exercise, and I'm curious as to what will citizens have to say to make you change your mind on the policy, particularly on the number of cycles. Because I think one of the things that we hear with listening exercises is you want to hear people's views. Probably a question for Alex in terms of, you talk about, looking to see who's responding. If you're not getting the core groups that you are looking to hear from and listen to, you're going to be agile to try and meet the other groups. So, I think that's great. But in 2 months, which has got Christmas in the middle, I think that's quite tight. So from a professional perspective of an organisation that does this as well, I would probably want to see a bit more of an extended listening period. But I'm just curious as to, what we've heard from Councillor Bailey in terms of particularly Basildon citizens. When we listen to Basildon citizens and taking Councillor Lee's point around listening to the right people who are affected by it, then I'm just curious, if it's not wholly a cost-saving exercise, what's the response got to be for the ICB to take note, to change the policy, understanding it's a East Midlands-wide collaborative approach. And I really want to, on a really positive, the fact that some of the moves to make more fair and equitable, I think we would all applaud. I think it's fantastic that we've expanded the ability for people who wish to be pregnant to be so, or to have the chance to be so. But we know that also increases the number of people that will be accessing service or wanting service. So it's swings and roundabouts. The better accessibility and equitable service increases the numbers, which then puts more demand on the system, and therefore something's losing out, which seems to be the number of cycles. So yeah, I'm just curious as to what would make you change your mind if you're listening to people.
I'll take that. So, as with all things, in this instance, the decision will be taken by the Integrated Care Board. It will be a decision made by people who sit on that board. And obviously, I'm not going to predetermine the outcome of that consideration or what people consider to be the most influential in making that decision. So I think it needs to play out in terms of hearing the feedback. I think what I'm offering is an absolute commitment that we want to hear the views. We will receive them. We will be presenting those views back to the decision-making body in due course. In terms of the methodology, again, I hear your points. I just wondered if Alex wants to come in to answer those about the duration of the listening exercise.
Yeah, happy to. I mean, we're talking about a period of 8-9 weeks, taking on board, yes, of course, the festive period, but that's a reasonable kind of chunk of time when government has set out some guidance on consultations, which this is not. They have described 12 weeks as being about your kind of gold standard, but at the time that was described for something like a new nuclear power station being constructed. So we need to be proportionate here, don't we? I do think that 8-9 weeks is a good chunk of time to hear from people, and we've already heard from a good spread of people all across the East Midlands. But yeah, as I've said, and I agree, Sarah, as we kind of go through the period, if it turns out we're really not hearing from the right numbers or the right groups of people, then I'm sure across the East Midlands we'll want to prioritise the quality and the depth of feedback rather than kind of, you know, a deadline that we've set ourselves. So we will keep that under review.
Thank you for that. Thank you. Councillor Henshaw.
Thanks, Chair, for bringing me in. Can we tease a little bit more from you out about the issue of consistency across the whole geographic area? Because I still think there'll be an element of postcode lottery in this in relation to treatment. There may be alignment between the East Midlands ICBs, but that just means the disparities will be along a wider area. And, you know, some people have mentioned that other areas, such as Kent and Midway and other areas, they have 2 cycles. Other areas are still remaining with the 3. So, you know, there seems to be a mismatch there from your perspective. The other issue for me is, and it's been touched on, the issue around trying to get this sorted before the NICE regulations or guidelines come out next year. I'm not sure you'll be able to tell us when possibly they're coming out. And obviously that's a bit of a time to wait. So the urgency of pushing it through from your perspective, why now? Is it? I'm hoping that what you said about it's not purely a financial situation, and it's more about developing a service. But you know, to us, I think it seems that the urgency to move before the NICE recommendations come out is alternatively because you wanted to save finance and money. But you know, you can expand on that for me. The other issue that I'm really concerned about, and I haven't got up-to-date figures, so I don't really know. One of you might be able to help me. What percentage of people or couples in relation to the UK have NHS-funded IVF treatment? And by the nature of adopting these new policies, do you think you'll be driving people, if one cycle of treatment is not successful, then you're driving them into the private sector? Are the same doctors that are doing the NHS work the same doctors that are doing the IVF private work? I mean, I don't know whether they are, whether they're not, but I'm just interested to know. And I wouldn't say that it's a policy that's directly trying to push people into private systems, but you know, I just worry about that. And I don't really think that we should be voting for a system that negates and worsens the service for people in Basset Law. because they're at a particular level of service now, and if we adopt these or agree to these, then that level of service will diminish, in my view. So to me, I couldn't support that. It's been mentioned about, and I'm quite happy with this, the amount that you're trying to be more inclusive with the same-sex couples and transgender people, but they will still only get, I presume, one session of treatment, so they'll be in exactly the same position if it don't work as anybody else. So there is an issue in relation to that, and I welcome the inclusivity and the updated language that you're going to be using. But we talk quite a lot in this council about mental health and the effects people have with regard to the mental health. Can you give me some indication on what support's available for the couples and people that are going through the IVF process that doesn't work? If it's unsuccessful, is there any support that they get if they get to that stage where everything fails? So that one must have a really traumatic effect on their mental health. I could ask a few more questions, but I'll leave it at that, Chair. Thanks very much.
Thank you, Councillor Henshaw. Do you want to say that, Alex?
Yeah, thank you. There's a lot there. I can certainly pick up some of the bits at the end around the kind of how it feels to go through the kind of pathway. But Victoria, do you want to pick up some of those earlier bits as well?
Yeah, I'll try and remember. I've written some down, but if I get that wrong, then just tell me. I think I mentioned before there's a legal responsibility on us to offer the same service to everybody living within our ICB community. And actually, we are exposing ourselves to potential legal challenge and risk by not doing that, and have been in that position now since July 2022. So this is moving to a position of equity as much as we can within our own ICB, but also to try and avoid that postcode lottery, getting across an equitable approach across a wider geography, trying to avoid that, the idea that we've got a disparity. So that's the rationale around that, and one of those. In terms of percentage of people having IVF funded, I'm not quite sure. Maybe Dave might be able to help with that a little bit more. Maybe some of these questions we'll need to come back to you to find some answers on. Dave, have you got an idea you want to offer?
So we don't have those figures as part of the information we have. We'll see what we can get, but we aren't responsible for non-NHS funded care, so we'll only have limited access to that information. There was a question on NICE guidance and when that will be available, what it says. So I don't know what the proposal will be in the new NICE guidance. They've not, the drafts haven't come out yet. We do have a process for considering NICE guidance, and if the evidence changes, that is considered as part of any of our services that we routinely fund on the NHS. There's two types of NICE guidance. There's guidance which is there for information and support for commissioning of service, this relates to IVF and fertility services. And then there's a technical appraisal recommendation guidance, which is where the evidence is so strong that there is a legal responsibility for implementation of that guidance within 30 days of receipt of the guidance. So if it comes out as a technical appraisal, then it's a must do, because the evidence is so strong. If the evidence isn't so strong, it's guidance for commissioners and providers, and then it has to be considered as part of the process. And clearly can't second guess the outcome of that process, because it's there for a reason, to look at what new evidence has been considered as part of their recommendation and what impact it could have on the local population. So that the concern, I guess, was, are you doing it now to save money from guidance that's coming out later in the year? The answer is we will still have to look at that evidence and consider it as part of any policy changes anyway. So that shouldn't change our decision timeline.
And then just to pick up the point you made, Councillor Henshaw, around the kind of emotional and sort of mental health support, because you're right, we spend rightly quite a lot of time thinking about this from a kind of clinical and kind of access point of view, but actually for the individuals going through it, it's a real emotional journey, sometimes with a really positive outcome and sometimes not. So we absolutely recognise that. And whilst there isn't a specific provision within our current pathways or this proposal around, mental health services for this specifically, individuals going through it will be able to access the kind of mental health services and support services that are available sort of more broadly. But the point you make is one that we've already recognised, and within the questionnaire that we're asking people to complete, there's a specific section about, my words, how does this feel, rather than just do you agree with, BMI being a criteria and that kind of thing. We specifically want to hear from people, because we could have the best policy in the world, but if the way it's implemented and how it feels for individuals doesn't feel right, then that wouldn't really be a success. So we're keen to kind of pick up that broader kind of aspect of, how does it feel to go through this process, so we can make sure we help set out our expectations on that as well.
Point, I asked the question about the people that did the work on the NHS, and then is it the same doctors that do it in the private sector? I mean, I don't know whether you've got that information, but I'd be interested to know.
It's likely to be a mixture of both. We haven't got the exact figures, but it isn't unusual for NHS consultants to offer private work, and there are a number of consultants who only offer private work in certain clinics. So it'll be a mixed economy, and I don't know the different ratios. But however, there is an expectation and a requirement that all people providing NHS care, their NHS care shouldn't come at to compromise if they're providing private services. So there's an expectation the NHS comes first.
Councillor Carr, please.
Thank you, Chair. I'm sorry that I was a little bit late, but there was an accident on Clifton Bridge involving a hay lorry.
Coming back from London.
I think you probably gauged the mood of the room, and I'm sorry if it feels a bit like you're in the lion's den, but that's, I think, how we feel. I've heard a lot today the word equitable and equity used. It's not an equitable policy if you're of mediocre financial means, because your choice is, if your first cycle fails, you either have to give up or you have to borrow money, and so that's not equitable. It's not equitable for people over the age of 40, who you've already said very often take 6 cycles to become pregnant, and it's not equitable for the people of Bassetlaw, who are now going to be very, very diminished on the number of these things. At the end of the day, this reads to me very much as not a medical decision, a clinical decision, but a funding decision. And quite frankly, I don't think that's fair. I don't think it's fair on these people. I have a very close friend who has been through this, and as you pointed out, Paul, it's a very, very traumatic time mentally, and causes all sorts of issues with regards to relationships between couple, and the added pressure that this will give, I think, negates the benefit that you're going to get from saving on funding. And I have to say, I hear consultation all the time. I'm sorry, I know I've been a councillor for nearly 22 years now, but the longer I become a councillor, the more cynical I get, I'm afraid, Mr. Chairman, and I apologise for that. When something goes to consultation, 99 times out of 100, it's a done deal. But what we've got to do here as a scrutiny is to say, well, actually, we don't like this policy much at all. And hear us. We are elected representatives of the people. You've got to listen to us.
Thank you. I don't think there's really a question in there, so we've got to Councillor Turner.
So it's not a financial decision. If that's the case, perhaps we should be asking Bassetlaw how they can provide 3 cycles when others are only providing 1, and perhaps taking advice from Bassetlaw on how they do it.
Mac and Victoria.
Yeah. So Basel Law isn't a decision-making body around commissioning resources anymore. So we lost that as a CCG when we became part of the Nottinghamshire ICB. So the responsibility of the ICB as a commissioner for the entirety of the population is that there is a consistency of approach for the entirety of the population. And at the moment, there is a disconnect between those offered, the service offered to Bassett Law residents as opposed to that offered to the rest of the wider Nottinghamshire population. So I think what you're saying is levelling up the number of cycles as opposed to levelling down from Bassett Law point of view. And again, that's something that will be taken into consideration as part of the listening exercise. As we've said, we are really trying to work across a broader geography with other ICBs to have equity across a bigger footprint to avoid a postcode lottery around this. We've said that it's not driven by finances. Finances are obviously a consideration, particularly in these very constrained times. We have the statutory responsibility also to balance the budget. But equally, in terms of the total impact of this policy, we recognise actually by extending the access to a broader range of people, actually we don't know the final financial implication of this. So that's why I'm saying that particular issue is not a financially driven question. It is our overriding obligation to make sure that we provide fair and equitable services within our affordability limits. That's what we're attempting to do by this policy.
Thank you. Councillor Doddy.
Thanks very much. It's an enormous amount of questions to have to throw forward today.
Councillor Dr. Doddy, GP.
Yeah, thanks very much. I mean, we're in a world where the number of babies being born for the first time is actually fallen below the number of people who are dying. So the natural population is actually sort of slowly decreasing. But the reflection on that is the fact that people are actually choosing to have less children. People are dropping down from the multiple children down to 1.2 or whatever, so the nuclear family is becoming increasingly smaller, and people are making decisions which reflect other things in lives other than their families, etc. There's no doubt that we'll see this time and time again. We're £100 million overspent in the ICB. And when I look at other services and I look at referrals into cardiology and neurology, etc., and most of them not able to get appointments and then having to go to the private sector, as Councillor Henshaw said, to see the exact same people, to have the exact same treatment, this is a reflection. However, in this particular instance, we're looking at the vast majority of the population, a million plus, who have a single cycle of IVF versus 100,000 people who've got 3 cycles of IVF. So is there a logical argument for levelling up or levelling down? The argument, of course, is to level down. You're not going to bring up the whole of the rest of Nottinghamshire to match Bassett Law. It just doesn't make any sense. Would I prefer the money to be spent elsewhere in the NHS instead of bringing the rest of Nottingham up? Absolutely, every day of the week. So, although it is an emotional argument, it's actually a clear logical argument. I'm more interested in some of the challenges that exist within IVF rather than the levelling down. We're talking a lot about IVF, which is just in vitro fertilization, which everybody talks about. There isn't a specific cost in here about that, but we don't talk very much about IUI or intrauterine insemination, which is a much cheaper process. We're down to 1 cycle of IVF across the cycle. Where are we with regards to the IUIs? I know we've put it at a 3. But when I was talking to colleagues this week, some people said, oh, I've had patients who've had 8 sessions, 9 sessions, 10 sessions. So in utero insemination is just taking sperm, taking the healthiest of those sperm, taking them out, taking a woman at the right time of her cycle, possibly creating ovulation or stimulating it, and putting the sperm into the uterus to increase the likelihood of pregnancy. And perhaps that's an element that we haven't sort of looked at here. Are we bringing Bassett Law up in that sense to the rest of Nottingham with Bassett Law at that level? Are the rest of us going down? Where does that actually fit in? In terms of the costs, if you look at it, in the actual financial analysis, it doesn't actually give us a cost for the uterine insemination. I don't know why, but it does give us a cost for the IVF. In utero insemination is not as good as IVF. Might only be 10%, might only be 15%, but it's not useless. But but it's certainly imminently cheaper, etc. So I'm not sure, Dave, where the actual balance is with regards to that, and where it brings us up to in that sense of things. I'm more concerned about some of the exclusion criteria, particularly around BMI. The BMI of 30, 70% of the population are overweight. We have an enormous obesity challenge. So, and lots of the diseases that cause infertility cause obesity. And I'm talking about polycystic ovaries and polycystic ovarian syndrome, etc. So there's a huge challenge of people to meet the criteria to begin with, never mind how many cycles they get. And that's something that I'm much more interested in with regards to that. Although there are, and we haven't touched on it today, special circumstances in all of these which the NHS take into consideration. Even though we have this policy, there will always be the opportunity for people to be considered as individuals and specialist circumstances taken into consideration, and that's always been the case in the NHS. I do, when we talk, Councillor Henry, about the one child type thing, and Councillor Henshaw about how we're introducing a new level where we have a cycle of IVF for a single person. That single person is one individual. If they're in a couple and the other person has got a child, the person who hasn't got the child, in my mind, is being discriminated against, because you've got a single person who only has to take into account that one individual, and it doesn't matter where the sperm comes from or whatever else happens, they are getting a priority treatment because there are no other people being taken into consideration. But that's the type of question I would be asking myself. Should the woman who's having the treatment be the only person that's important in terms of having a child because she hasn't got a child, she's got the infertility problem and we're offering it to her? So there are a lot more areas that I'm interested in rather than levelling up and levelling down. I think one session of IVF is fine. That's enough for anybody. I think that the challenges are around access to the service, making it available to more people, and of course the financial argument. I think the money can be well spent and divided and spent in other areas of the NHS. We've got a maternity service under investigation because we haven't got the midwives to deliver the babies safely in Nottinghamshire anyway. So perhaps we should be spending more money there. So in summary, although the overall feeling here is that we should be levelling up, my belief is entirely that it's perfectly natural to take the majority and move towards the majority, which is one IVF session. I would like more information on the IUI, and I think it's poorly understood. When we go there to consultation, people will not understand the difference. People will not understand what IUI is because they have no knowledge of that. So they all think that's the same thing, the same cost, etc. So just a little bit on that, and also how many people feel that, as Councillor Henry and Henshaw pointed out, that the child of the partner is perhaps somewhat irrelevant when we're offering it to single people who haven't got that exclusion criteria. And they're just the concerns I've got, but overall in terms of the one cycle, I have no problems with that.
Thank you, Councillor Duddy, and thank you for a bit more medical background and understanding of the situation. Do you want to take that, Dave?
Yeah, thank you. So the in utero insemination, the policy is consistent already, and it's not changing. Three across the board of unstimulated IUI. I think getting the wording and the nature of the information better, I think we'll go away and look at again, because it is quite a complicated topic, and we need to make it more user friendly, I think. So we'll take that on board. I think it's also important we take on board all feedback, but specifically around how it will feel for a single person who has access to a cycle of IVF compared to a person who's got a new relationship, has in it, whose partner has a living child and you haven't, and how that might feel unfair. How that will feel unfair. Apologies, I'll get my language correct. And we will make sure that's specifically considered as part of the work. Yeah, well, we can provide some of the different costings outside. I know all the interest is much cheaper. Yeah, it's also a lot less effective as well. So I think the the balance of that. So the recommendation is for those people who aren't able to have intercourse, they are able to go straight to IVF if they don't want to consider IVI because of the low success rate with it. So we will make that language clearer. We'll take that specific concern around how that will feel to those people in that specific circumstance on board as well. Thank you, Councillor Doddy.
Councillor Adams.
Thank you very much indeed. Yeah, I'm glad that happened. John Doddy brought up the point there around the fertility rate, because I think maybe the question that we're asking here is the wrong question, or maybe we should be asking how do we increase fertility rates across Nottinghamshire rather than reviewing to effectively put it into decline in some way. I take on John's point around the fact that if there are alternative ways of achieving that, let's make sure that's widely known. But I think I do take a little bit of an issue, Alex, with your point around consultations. You made the point that the nuclear power station required 3 months. Arguably, this for me is a much bigger issue, and I think effectively what we're saying is in a population that's declining, like John Doddy said, we're at 1.44 rate at the moment. In 1964, it was 2.93 per household. It's the lowest on record, and the knock-on effects of having a declining population across our population, not only to fund the services that you all sit here working for a start, but secondly, to ensure that we can create future opportunities for our country. For example, in terms of innovation, younger people generally will be the key innovators as they come into markets and look at things with fresh eyes. The negativity of what happens when you have a population in decline, the effects it can have on the economy in terms of permanent recession and things like that. So there's a lot more that, in terms of the knock-on effects of getting a policy like this wrong, than there is of whether we build a nuclear power station somewhere or not. So I think we've got to take the seriousness of this more seriously, and I think it should be getting at least a parity with a nuclear power station, if not more, to get it right. Because the decisions that we make on fertility policy now could have massive knock-on effects for generations to come. So we've got to get that decision right. I completely agree with what Councillor Bailey said and Councillor Lee. Let's not force this problem down even more. Let's not reduce this fertility rate even more. Let's get the best case fit across the whole of the Shire. And if that means we do take some money out of something else, and this is where I fundamentally disagree with you on that, let's take it from somewhere else and let's get it into this. Because we increase that fertility rate, we increase the population rate, the knock-on and positive effects that has throughout our country are massive. So for me, this listening exercise should cease, and you should go back and ask the new question: how do we increase fertility rates across Nottinghamshire?
Thank you, Councillor Adams. Do you want to take?
So I think there's obviously a bigger local and national conversation around population rates and national fertility. I mean, and that's clearly a really important topic we would never want to undermine. I think the question raised again is the view of this group is that the number of cycles of IVF should go up, not down. And I think we can take that back, and that will be considered as part of the listening exercise. And it's not an entire view, but there's been quite a lot of views that ought to be the way we're considering it. And we will, of course, take that back as part of the listening exercise. In terms of fertility rates nationally, that is obviously a bigger issue. It's an issue for local council, local government, and the sort of the national government. I'm not sure that's our place to go out to an exercise on how we might increase fertility for our population, important as that may be. But we will absolutely listen and hear that there's dissatisfaction and a guidance that we ought to be levelling up rather than levelling down with the number of IVF cycles as a feeling generally, but not universally, of this committee.
Thank you, Dory.
So, I do want to recognise your really important point. I absolutely do agree with Dave, but I think it was a really important point that you made. Councillor Doddy will know from the various Health and Wellbeing Board conversations that we've had and the work around place-based partnerships to support that broader agenda about how do we support people to be healthier, that will increase their opportunities around fertility and a number of other improved life experiences, you know, having a longer, healthier life expectancy. I think that's an agenda that we all need to get behind and really support. And I know that colleagues in our public health teams, the County Council, the Health and Wellbeing Board and the ICB and the ICP are absolutely on that agenda and trying to think about how do we encourage that prevention agenda, supporting people to live healthier lifestyles wherever possible, eat properly, don't smoke, and those kind of things. So I think it's a really important point that you make, but it has wide ramifications for a whole range of things about people living healthier for longer. But I just want to recognise the point you make, and I think it's well made.
Thank you for that. Councillor, I'll bring you back in for a second question.
Thank you.
As long as it's a new question.
It's not a question. It's I want to look at changing the recommendations.
Noting.
Yeah, no, and I want to change it from only noting. And I think it's how we're allowed to do so. The recommendation should be changed from only noting should be removed. We don't support any changes to Basset law being reduced in numbers of IVF. The second one, that we advise that the listening exercise should be changed to a legally binding consultation, and that there should be no decision until after the recommendations of NICE have been released in February. And that should be our advice to them, and it should be put in the minutes, so then it is clear and open that we do not agree with what you are looking to do.
Thank you. Well, we can probably talk about that when it comes to recommendations anyway. Coming on, I don't think there's any further questions on this. I think you've got a general feeling that the committee is not really behind this policy at this moment in time. You know, probably a bit of an understatement. I was going to say what Councillor just said. You know, the NICE guidelines. You never really. I don't know whether you know what the new NICE guidelines are, but you never really indicated what they are, but whether they're going to change or not. And you never really asked the question, why are we not waiting until they come through? So you've got an indication, don't know what they are. So why aren't you waiting for the indication of the new guidelines are before you formulate your policy? You know, it's been mentioned. We're on you know, the back of, you know, the birth rate is a lot lower than it should be, and the implications that might have. You know, people are having children later in life, so they're less fertile, and I believe that the sperm count in males is going down as well. So I think the chance of people having children is a little bit less now. So we probably should be, as I said, we should be looking at how we make people more fertile, but how can we help them have children? Because we're in a situation now where I think it's more difficult for people to have children. You know, and I don't think it really answers Sarah's question of what will make you change your mind? What can we do to persuade you that this policy is not quite right at the moment? And how would you change it or put it back until we hit the new NICE guidelines? You know, why are you really rushing this through?
Point of clarification, Chair. There's no evidence that there's a failing fertility rate in the country or in the world. We're at a population of 8 billion people. People are choosing not to have children. People are choosing for financial reasons to have smaller families. People are choosing to prioritise their careers. People are choosing to have lives where they don't have children and they can go on foreign holidays. The idea that this is some sort of an epidemic of a lack of children in this country is a complete nonsense. And the fact that this would have the slightest implication in terms of the numbers of children born through IVF on the population of this country, complete nonsense.
Just to return on that, if we're only offering a limited amount of access to it and people have to go private, and that is a financial decision a family has to make.
Thank you. So, I mean, I don't know whether you want to come back on what I just said, or whether we just said the comments of this committee before we move on to the record. Viv, did you want to come in? Sorry.
So, just to be clear, there's no decision has been made. So I think the question was, what would it take to change our decision? Well, there's no decision being made. The decision makers will be receiving the information from the helpful advice that you've given here, also the listening exercise, and those decision makers will need to have taken due heed to that advice, that feedback from the population about what this means in that wider sense of investment of resources. So it's not about overturning, because you can't overturn a decision that's not been made. It's about us accurately capturing the views of our population, accurately capturing the views of this committee as part of that decision-making process, which we are committed to do.
Chair, could you ask Public Health to update on the population movements and directions and choices of Nottinghamshire? We have the Chair of Public Health here, the Director of Public Health, who should be able to give us the correct interpretation. Over to you, Director.
She has indicated she wanted to come in, so yeah.
Thank you, and some really valid points today. And I think one of the things that we do need to acknowledge here is that infertility affects people physically and emotionally. And I think some really important points have been raised here. In terms of our population projections, I've got the JSNA up in front of me. In terms of we do know that our population is likely to increase over time. In terms of the specific proportions, we know the greatest increase will be in our over 65 population, because we know that we've got an ageing population overall. So we're looking to see a 17% increase in population change by 2030. Sorry, let me just double check that. I've made sure that's for the ICB. If I go to Nottinghamshire overall, that's just over 17% again. We will see within that, though, increases in our 15 to 24 population and our 24 to 44 population. So talking around some of those working populations that we do know. So our population predictions at the moment are expecting that we'll see a slight decline in our 0 to 14, so just under 1.5%, but an increase in just over 12% in our 15 to 24 population and our 24 to 44 population. So what I'm trying to say here is there's an increasing population, but where we're seeing those increases is not the same in each age group. So just to be aware of that. But I think you make some valid points, Councillor Doddy, in terms of we know that families are choosing for a range of factors that are individual to them to have their children at different stages in their lives, and that's got to be right for them. But we do know that the average age of having your first child is slightly increasing. So there is potentially an impact in demand on people needing fertility services, because we know that the risk of or your likelihood of having a child without support increases with age, as Dave and the team have mentioned before. So I suppose there's something for me around, I really welcome the fact that this policy is more equitable overall, but I do think we need to think around how it is equitable to all populations. So the policy particularly talks about same-sex female couples. We need to also think around what impact this have, or what support we have for our same-sex male couples or our transgender women and men. So I suppose there's something for me around, as part of the consultation, I'd be really keen to support the ICB with this, but think around how we are engaging with those populations who may be more difficult to reach. So how are we linking with some of our voluntary and community sector to link with our same-sex couples, but also our transgender population, and we might have some links with our sexual health services, for example, that we can consider in terms of how we do that. But I don't know whether that's answered some of your questions there, Councillor Toddy.
The question was, is the population of children being born down to choice of people having less children, or some sort of infertility epidemic?
So we're not. I don't think we'd need to look at the exact evidence. I think, as Dave has mentioned, I don't think we're seeing significant increases in terms of that aren't age related or other factors related around fertility. But what we do know is, if you are at healthy weight, you are a non-smoker, if you have reasonable or no alcohol intake, your chances of conceiving naturally are higher. So I'd be really keen to think around how we know that people deciding to have a baby or choosing that that's the right time for them is a really important point in their life, and it's a good time to think around how we can support some of those healthy lifestyle interventions, which will support and then links into some of the criteria that is mentioned in the policy today.
Sarah.
Yeah, I just wanted to come back on the use of the word equity, because I think what you've got is an equal approach to different groups that would face fertility issues. What you've not got is an equitable policy, because you've already mentioned the difference in age and the number of cycles that are required to have a more likely percentage of success. So if, for instance, an equitable approach, this is just a sort of example, would be that you might give under 30s one cycle, you might give over 40s 2 or 3 cycles. That would be an equitable approach, because it then looks at the difference in the experience of those patients, rather than just giving everybody the same, because not everybody is the same, and the evidence is there to demonstrate that you have different efficacy dependent on a number of factors. So I think we need to be careful when we talk about equity. For me, there's an approach to being equal in terms of having new groups of people given much more access to this through this policy that's been proposed. And I think that's the bit for me about being a proposal and answering that question about what would you need for that proposal to be changed, because the proposal's out there, and if you then, it's when you start giving it to the decision maker, it's how it's presented. So a listening exercise is you'll take everybody's opinion. That could be based on a very small number of people, depending on how well I know Alex's team's really, is good at doing what it's doing, but it could still be a very short number in this particular time frame, and then making sure you've got enough listening from different quarters of the population that are particularly affected by this policy. I think that's the bit for me I'm interested in is, and I'm interested in it professionally in terms of my business is listening to people's experience and helping them change the decisions that are made by commissioners like the ICB, like the county council. So I'm really interested in what would you need to be hearing from people for that proposal or those recommendations to be shifted one way or another. I'm not preempting what people might say, that's not my business. But what I'm interested in is ensuring that when people give you their opinion and you listen to them, how is that translated into those recommendations that are given to the decision makers? Yeah.
Thank you. Some very good points there.
That.
No, some very good points there. Actually, I think what coming out of the consultation, and people come out with weren't their true feelings, I suppose, about it, which needs to be filtered through. Come to recommendations. Recommendation 1 is that the views of members regarding the proposed changes to criteria and access be noted. Recommendation 2 is that a further update be received when the 2025 NICE guidelines are published. Now, Councillor, you wanted to answer that or change?
We don't support any reduction in numbers of IVF.
Microphone.
Sorry, Chairman. That we don't support any changes to Bassett Law's IVF numbers. Number 2, that you need to change your listening exercise to a legal consultation. And number 3, that no decision from yourselves should be made until after the NICE recommendations.
Second that, Chair. Point of order, Chair. I think we need to go to democratic services. I've never heard anybody do this before.
No,
this is a paper for noting. And you might agree with it or you might not agree with it, but it's not a paper to come up with its own ideas of how we should run the fertility service.
Precedents has already been set. Precedents were already set in governance and ethics last year, where we had a thingy for noting, and we were advised by Councillor Pringle that this council don't note things anymore. We've agreed that we won't note things. We make decisions.
I don't think that you should be allowed to do that. I'm going to go over to democratic services and say you can note the paper or you can raise an objection to the paper, but you can't change the material request that exists within that. You might as well say, we should all have an umbrella if it starts to rain, Councillor Lee. I don't think you should be allowed to do that.
It's been proposed and seconded, Chairman. It'll be up to legal to advise, I'm sure.
Legal, can we have an advice on this? I think it should be postponed at intervention, subject to further legal advice on it. Completely changing papers to come before us is ridiculous.
To be fair, Councillor, what you're proposing has been said by this committee. I'm sure that the members of the ICB have taken that on board as such.
But what would be the problem with just putting it in and voting on it? If they're going to take it on board,
I'm not
anyway,
voting,
then
it's
there's
just
no
for
difference.
noting. So,
but we don't note things at this council. It's already been agreed in governance and ethics that this council don't note things anymore. It was agreed.
No, I disagree with that because we've noted that things at lots of meetings recently, including the pensions committee the other day. So,
Can I just?
Oh yeah, Catherine.
This recommendation, Chair, is not what the committee is doing. This recommendation is what the ICB are recommended to do, as far as noting the views of members that have been.
Yeah, the recommendation is the recommendation on the proposal on the paper issued by the ICB that their members they note our conversation and our recommendation, our recommendations, our conversation from this meeting to take on board when they make their decisions on the policy. So I don't think adding any more to it will make any difference.
Can we check with them that that's what they are?
Are you happy with that?
So the views of this committee have been really well expressed, really clearly, and we will fully incorporate them in the work that we take going forward. As colleagues have said, they will form part of our listening exercise. That has literally occurred today. We have heard it, and it will be incorporated into the totality of the evidence, which is then presented to the decision makers when we come to that stage. So I can give, I think, categoric assurances on that.
So will you be coming back to us before you make your decisions?
If the committee would like us to come back and update, we're at your service. We'll be very content to do that.
Can I just say, though, Chair, that given the timings of the consultation, I think that's likely to be right in the middle of the election period.
I don't know, when is the length of is it 2 months?
So this listening exercise concludes on the 10th of January. We will then have a period to gather that information together and start to think about what our next steps might be on that, which could be on a whole spectrum of, I'm speaking off the cuff here, correct me, Victoria, we could say, great, that's the policy decision made. It could be, we want to make some changes. It could be, we'd start again. This is a listening exercise on a current proposal to understand what our next steps might be, Victoria.
Yeah. So just...
I just asked them, do you think that'll all be concluded well before the 27th of March?
If we've got the listening exercise concluded in January, we're more than happy to come back in the new year and talk to you about what we found in the listening exercise and where we are in the process and what we think we're going to do next steps. We're more than happy to engage with you around that conversation. I can't give you categorical assurances around any time frame. That would be very silly of me to do so, but we are more than happy to continue to engage and obviously give you the opportunity to hear what's been happening in the process.
Okay, we have a meeting in February and the 25th of March. So the 25th of March we won't be in Perth by then, will we? So when you had your listening exercise, you come back to us either February or the March meeting. We'll try and arrange that just to see where you are with it. Does that meet with members' approval? And we accept the normal notes for noting recommendations.
I think for formality, Chair, you've had a proposal and that's been seconded. So are you now saying that that's invalid and we're not putting that to a vote?
I'm not actually sure, Councillor Henshaw, whether we can actually change. Sorry.
Can I just help a little bit? So the recommendation that the chair's read is that the views of members regarding the proposed changes, to the criteria and the access, is being noted. So that includes all of the views that have been taken in today, and we've received assurances that's being consider.
I'll make it easy. I'll remove my own proposal.
So
I'll remove my
Yeah, thank you. I think the views of this committee have been strongly put forward this morning.
I agree. Sorry, Chair, I agree with you because I would have voted against the proposals because it's quite clear that they've listened to what we've got to say, they're going away and they're analysing that and they're taking our views forward. And we are noting a report that's come from them. So yeah. I would vote, but now he's withdrawn it anyway.
So we're happy to move the recommendations and note recommendations as they are at this moment in time, and we'll invite them to come back either in the February or March meeting to see where the progress has gone on this consultation exercise. Okay, thank you very much for that. Oh, well, all in favour of the noting? Yeah, thank you very much indeed. Thank you. Thank you, Victoria, Dave, and Alex for coming on this morning. It has been a very in-depth conversation, debate. I hope you take on board what members have said actually, because some of it was quite passionate. So yeah, thank you very much.
Thank you, and yeah, again, very helpful, very nuanced and detailed discussion. So really do appreciate it. Thank you.
Thank you, members. We'll move on to agenda item 5, which is the healthcare winter planning. And I'd like to welcome the RCUB representatives, Gemma Weissel, Systems Delivery Director from Urgent Care, and Hazel Buchanan, Associate Director of Health Inequalities and Clinical Strategic Programs, to today's meeting. I think that's a bit of a mouthful, that was. Sorry about that. And Dave, thank you for staying on. You obviously grew up for punishment, yes, this committee, or just love this committee so much. Thank you. So can I invite Gemma and Hazel to please present the report? Sorry?
I need to bring up the slides, Chair.
Oh, you need to bring the slides up first, okay.
Wait.
We're waiting for the technology to work. If you like to, Gemma, yeah, I mean, we're just waiting to reboot for what it has to do.
I have had the task of pulling together our winter plan across all system partners across health and care. One of the key lessons that we've taken on board from last year is to start that process earlier. So we've had fantastic engagement from all system partners around reflecting on winter last year and making sure that we embed those lessons learned into this year's plan. And actually, the very first conversation we had was in April this year to start the planning for this winter. There is a group which is very well attended by all system partners. Every fortnight we meet, and we've been developing content for the winter plan, most of which is included in the report that you'll see today. So the process that we've gone through is every organisation has their own winter plan. They go through their various committees or boards to sign off what they as an organisation will commit to over the winter period, and then I bring that together on behalf of the system. So we've got a number of key principles set out in this year's winter plan about making sure our population get the right care at the right time, right place first time wherever possible. That we absolutely work together as a system. We know that winter there are lots of things that happen, including the weather and snow this week, that affect the urgent and emergency care system. We've absolutely got to make sure that we balance that clinical risk, and colleagues such as Dave are absolutely central to working with us on how we do that day by day across the winter period. It is about all system partners playing their part and managing the needs of our population over winter. And we have pulled together our key system risks. So every organisation develops a plan and we pull that together at a very high level. And they are about making sure that our performance is where it needs to be over winter, that we are managing the demand that comes into urgent emergency care in particular every day, and that we're mindful about staff sickness rates. And I know Hazel's here today going to touch on the vaccination programme. We absolutely want to make sure that wherever possible, all of our frontline staff receive those vaccinations. We're overcoming estates challenges and making sure that we are taking into account all of the modelling that comes from the Southern Hemisphere around when and how respiratory and influenza peaks happen, and that we play that into our local modelling. So just to touch on some of the key reflections that we had from last year, we've absolutely built those into our winter plan this year. First one was starting early, so we started it in April, but also recognising that winter doesn't necessarily happen in a linear way. So actually one of the things we've had to do already is we've recruited temporary staffing into the acute trusts, and we've already utilised some of that to cope with the peaks and the flexibility and demand that we need to manage urgent emergency care. I think I've mentioned already the importance of having strong communications. I know Alex is here today and he pulls together all of our system communication leads on a regular basis to make sure we're sharing consistent messages around what's happening across our urgent emergency care pathways over winter. Just a couple more things, Chair, to touch on. We have a system coordination centre in place, so that operates 7 days a week, 8 till 6, and that sits within my team in the ICS. So what we do is we look at peaks in pressure and peaks in demand across the system. So that brings together everything from 111, primary care, social care, what's happening in the ambulance service, in the trusts, with our mental health service, and we look at how do we together work on managing that demand today. We've got fantastic data available to us, and that's reviewed 7 days a week. The team are really good at looking at what does that data mean, where is our pressure, and how do we respond today. And then I've just given you a flavour really of all of the meetings that happen. So every day we have 3 system calls that take place with all partners. We're actively working on discharging patients in a timely way, so making sure that they've got the care that they need to go home today. and absolutely underpinned by making sure that our winter plan is modelled and understood on a daily basis. I'll hand over to Hazel to touch on the vaccination slides.
Thank you. So the full rollout of the flu and COVID programme commenced on the 3rd of October, with the expectation that most people would be vaccinated by the 20th of December. So we're just past halfway or in getting into the end of the programme. The flu is predominantly delivered by GP practices, and COVID is predominantly delivered by community pharmacies. Across both of them, they do the large majority of the vaccinations. Around that, we look at other options to increase vaccinations, and this year we have got a mobile unit, which is going into areas where we don't have the full COVID coverage, so that we're able to provide additional access and opportunities to have the vaccinations. We're also looking at carrying out a targeted program for those who are frail and those with a respiratory condition. And this will be where we'll be reaching out to individuals specifically to encourage uptake of the vaccination. As part of the programs, we identify providers for all of the care homes and those who are housebound. And these are part of the contractual arrangements as well for flu and COVID. Also, as part of the program, all NHS trusts provide flu and COVID vaccines to patients that have a 21-day or more length of stay. NUH are also offering opportune vaccines to those who are attending outpatient appointments and haven't been vaccinated. And that has been proven to be really successful in reaching out to individuals. The frontline health and social care workers can access flu and COVID vaccines, and trusts all have staff vaccination programs in place. Nottinghamshire County Council has implemented a programme for frontline social care workers. So we work closely with the local authority, and the local authority do considerable work on supporting the campaign through comms and reaching out to local communities. And we also use the national programme to really support the uptake of vaccinations. And this will continue throughout November and December. And so alongside the vaccination program, I was just going to mention that we also have programs for flu antivirals and COVID antivirals, which links to what Gemma was saying about keeping people well. The flu antivirals are prescribed in the situations where we have outbreaks in care homes, and so then antivirals are given to those who are at risk of flu, as well as those who have been diagnosed with flu. The COVID medicines delivery unit provides oral and IV antivirals, and that's on the basis of a positive COVID test and for those with symptoms. So both those programs continue throughout the year, but obviously fundamentally they're key for keeping people well during the winter period. The paper includes uptake figures, and I was just going to mention, so obviously the uptake figures have increased since the paper. So at the moment for flu in Nottinghamshire, we're at 46%, and for COVID, we're now at 42.4%. We do see a really much higher increase in, or much higher uptake, in those who are 65 plus, and in particular those who are 75 plus, those who are 65 and under and who are at risk. We see lower uptake, and that's where we really want to try and reach out to those groups of individuals to obviously increase uptake. That's it. Thank you, Chair.
Thank you, Hazel. Thank you, Gemma. Yeah, thank you for that paper. I'm sure there's lots of questions coming out. I mean, I have one the thing. You said you started in April, but we're now in November, talking about it in November. I mean, probably this could be we're probably talking about it a little bit earlier about your planning, going forward, because we're into winter now, sort of thing. And the uptake you said is where it is, but to me it still seems very low for the time of year as we're going into winter. I mean, and have we learned from past years where we've gone wrong, where we should be improving? No, getting a bigger uptake. I think it's very important that especially critical workers and care workers do get involved in the uptake of the vaccines and inoculations and that. Yeah, going forward. But you could probably bring those. I'll bring the commission now. Being probably answer those in a minute. I've got Councillor Carr first, please.
Thank you. On page 37, and you've already touched on the cold and flu vaccination update, which on these figures isn't brilliant, is it? But that's not for want of trying. I mean, I have every vaccine that's going. I've always believed in that. The only reason why smallpox that is now extinct is because of vaccinations. It's quite straightforward. What can we do further to actually improve that? One thing we did during COVID was we released figures for individual areas. So at an early stage, I found out that part of my division, Beeston North, was very low, and we got people we had the bus then. It was taken to that area to give the vaccinations there. Also, you brought up the subject of antivirals. I'm aware that is no longer done in any of the Nottingham hospitals. When my wife is immunosuppressed, last time she caught COVID, I had to drive her to Kings Mill, which is a long way from Beeston. I had COVID as well, and she had to walk through the emergency department at Kings Mill with COVID to go and have her antivirals. What is the situation with that now for auto-suppressed people? And there was another one, but I can't remember what it is, so I'll leave it there.
Thank you. Would you want to come back on those questions?
Yeah, so on the antivirals, the IV antivirals, which I believe is what your wife requires, are at 2 locations, and one is at the PC24, which is outside of the emergency department at Kingsmill Hospital, and the other is in Nottingham City. So yeah, so there's the 2 locations to make that more accessible. And in relation to uptake, we're trying everything to increase uptake. It's you've got the vaccine hesitancy. We can really see across different communities that people aren't engaging with vaccines, and so it's very much about how do we reach into those communities. And so it's how do we, what we're looking at is how we work more with local resources, with our community champions, to really highlight the benefits of the vaccination. But it's very much has to be a partnership, multi-pronged approach to increasing the uptake of vaccinations.
I remember the third, is that all right? It's about pharmacies and how important they are in this. And of course, I think, is it January, they're starting industrial action? Do you think that might impact at all?
It probably won't impact on vaccinations. I think it may be some of the other areas, but the community pharmacies are obviously as you say, an important asset for the vaccination program, and they offer walk-ins as well as appointments. So really important for the for having that access in local communities.
So just addressing the issue about potential industrial action or industrial action locally, we've currently got communal action from GPs, which isn't industrial action. It's an agreement about what services they may provide. We've got an active process within the Integrated Care Board, working with partners in the integrated care system to understand impact and how we mitigate that. We'd adopt the same approach for any potential pharmacy action.
understanding what we'd need to do to maintain safety and effectiveness of services during any of those bouts. The cause and reasons for international is for national discussions, but we recognise our role in minimising the impact on our population.
Can I just mention on that I actually asked for the GP contract to come up before this committee, and it never has done. And because I did warn that this was bumbling up within the GP community because of the anger there was with regards to the new contract, but perhaps it's something that we could actually bear in mind moving forward, that if a councillor raises something like this, that we actually take it seriously and we discuss it. It was before your time.
Sent me the work programme, Councillor Cock. Councillor Henshaw.
Thanks again, Chair, for bringing me in. When I first read this report, I went, only 31% uptake of COVID and only 38% for the flu. Bearing in mind that we all know that to ease quite a lot of pressure on the NHS, we need to make sure that as many people as possible are vaccinated and protected. But now the latest figures have been sort of imparted to us. I'm a little bit more reassured. I'm particularly interested in the part on 37 about the access for care homes and people in care homes to access the vaccination, and if 100% of care homes and housebound have been offered the vaccination, have we in the figures a percentage of what the take up is in that specific area? Because when we had COVID, there were all sorts of, and it's being investigated now with the COVID investigations, but discharging people from hospital, and there may not have been a vaccine at that time, into care homes, which led to quite a lot of deaths and things. But yeah, and the interesting thing with me is I think most people understand the value of, or perhaps I'm wrong, understand the value of having a vaccination to help prevent illness. But things can change. I mean, across the water now, they're having somebody in charge of their health system that's the sort of vaccination denier, and we've got to challenge people that are reticent to go for vaccinations with the science, and the science is clear that vaccinations help prevent illness, and if we prevent illness from people going into the hospital, that will have a better effect on the services that the hospitals provide. So I'm just interested in that figure. Thanks.
Thank you, Councillor Henshaw. You can take that one. Yeah.
So we have, as mentioned, we've got providers assigned to each of the care homes. So for flu, it's the GP practices, and for COVID, it's a combination of GP practices and a Trenside Medical Group who are covering all of the care homes where practices and vaccinating. We get full reports on care home uptake and how many people within that care home have also declined a vaccination. So we are able to monitor. We also get information where there may be challenges in accessing a care home for whatever reason it may be. So we work across our care home team and with the local authority to make sure we're reaching out to all care homes. But absolutely, there's 100% offer, I mean, obviously we aim to have all residents vaccinated, but they do have a choice not to be vaccinated. So we monitor that closely, and as I said, throughout the programme, we continue until December 20th is the date when we expect to have everyone vaccinated.
Thank you. Councillor Anderson.
Thank you, Chairman. Just referring back to the table on page 37 regarding the COVID and flu vaccination update. I know we've established that the levels of COVID and flu are low, with a 38 and 41% take up respectively. I was just wondering how these figures compare to previous years, and do you think that there is a case of vaccine fatigue after the impact of the COVID virus? Thank you.
So when we are looking at the figures compared to last year, flu is around about the same trend, but we are seeing a considerable drop in the number of COVID vaccines. What we also saw this year is the first 2 weeks for both flu and COVID really good uptake, but then a significant drop. So there absolutely is vaccine hesitancy. There is people feeling that they don't want the COVID vaccine as well. And these are all things that we are working with in relation to the comms. How do we reach out into communities? How do we encourage uptake of vaccinations?
And just following on from that, I mean, I have both of my those vaccines at a pharmacy, but it's sometimes increasingly difficult to book them. You have to go online, you have to enter lots of information. If you need somewhere that's got parking, if you've got mobility problems, for example, you can't, from the experience I've had personally, you can't just walk in and book one in the pharmacy. You have to go online. So just thinking people that don't have access to that, or people with English as additional language, are they catered for within that facility to book and attend a vaccine?
Yeah, so they can call to book vaccines and then talk about through that what would be the best option, or reach out locally. There's also, of course, GP practices, and through the telephone when they call to book vaccine as well through the national booking system. They can get support in different languages. So we do try through the community pharmacies and the GP practices to make it as accessible as possible. There we have got the mobile unit, as I mentioned, as an alternative. That admittedly that is limited, but because it's one mobile unit. But what we're trying to do is learn from this year whether that is helping to increase uptake, and therefore what more can we do in future years. But the community pharmacies, we have 107 community pharmacies delivering the COVID vaccine, and the majority, they'll almost certainly all be doing the flu vaccine as well. So across Nottingham and Nottinghamshire, we have got really good coverage for community pharmacies. And they do try and make themselves as accessible as possible. So I'd hope that if someone contacted the pharmacy, they may be able to get a vaccination if they weren't able to go through the national booking system.
Thank you. Councillor Reddy.
Thank you, Chairman, and thank you for all the information in this report. It's I can see so much work has gone into it. I suppose I've got a couple of questions regarding the number of beds. So on page 36, for example, it says 96% at Sherwood Forest hospitals. Anecdotally, at one of the governors' meetings I was at, and then at Health and Wellbeing Board, one of the other councillors mentioned that there are fewer people. It's at an all-time low or a 4-year low of people who can go back into the community, which basically means there's more acutely ill people in hospital that actually need to be in hospital. Has that been built into what you've looked at? And then I was also sort of thinking to myself, a couple of years ago there was that sort of diagram communication. Where should you go when you've got X, or where you should go when you've got Y? And I don't know if we really have brought that back so people understand they go to the GP or they can go to the pharmacy, and really sort of explain to people where they should be going as opposed to turning up to A&E. I don't know if we communicate that enough, so I don't know if it's something that we need to do more of, I suppose.
Yeah, so absolutely. On the bed occupancy, we've modelled day by day, almost hour by hour, what has happened in the last 5 years. But also as a system, we've worked really hard on our discharge programme. So Sue is in the room today and working really closely with Sue. So taking Sherwood Forest as an example, everybody who is medically fit to leave the hospital today, can they go today? If not, why not? So we're absolutely trying to make sure that as quickly as possible we get people discharged. And we do that day in, day out across the system. But yes, all of the occupancy levels are built into the winter plan so that we know how many beds we've got and how much demand that we've got on every single day. On the comms plan, it's a really, really good point. So I know Alex is here in the room as our director of comms for the system. He is meeting with communications leads from every organisation to say, what can we share more of, what works, what doesn't work. But absolutely take on board that point is, we try every day and push out messages about pharmacies, about GP practices, anything other than ED. But yeah, you're absolutely right. There's always more that we can do.
Following that, if there's any communications you've got that we can share on our platforms, please pass it our way as well, because we can share it among people and community groups as well.
Thank you. Sue, did you want to just come in on the winter readiness and over the holiday periods that we talked about? Mentioned, just to bring members update on that.
Yes, so from a social care perspective, we've worked really closely with the system. A lot of it is building on what we do all year and making sure that we're retaining our workforce, growing our capacity. So at the moment, once if people we're in the hub, so we're making decisions as people are referred from the wards. And once we know about people, we are able to support people home the same day or the next day. So our plan for winter is just how we make sure that we retain our capacity to maintain that flow. And we've used some of the discharge funds 18 months ago to boost our social work capacity. So for people after they've had a period of reablement or rehab, that we can quickly get to them if there's anybody that they think needs a care act assessment for ongoing care. And we've got good capacity in our home care providers as well, so that they're picking up people. The thing that I'm proudest of is last year it was the first time as a system we didn't buy spot purchase residential beds for people who could have gone home because we didn't have that capacity. So we're planning to maintain that position over this year, and that obviously really helps with spread of infection as well. So yes, we're prepared as we can be.
Thank you for that, Sue. Sarah, you wanted to ask a question.
Thank you. I'm going to go back a little bit to the uptake of vaccines and how you mentioned that you started planning in April, which is great to hear. But I think one of the key things for me is around the communications of how you communicate with the populations that you need to communicate with. And in the papers, it's asking for how we can look at collective actions. And one of the key things for me there is looking at how and if you've involved the VCSE, the voluntary and community sector, in looking at how they can promote the vaccination programme going forward. One of the things that NHS England done in the past, where they've provided communication packs for stakeholders with banners and things that you can use on your own socials, on your websites, that gives a coordinated message and a clear message that you can provide to any type of stakeholder to be able to use on theirs. Now, obviously, this is going through the county council's communication schemes. That's great. However, I've got nothing at Healthwatch other than me saying in an email to somebody, do you want to make sure you know about the vaccines? If you were providing us with those banners or just the graphics that we could use, we could put them on our headers of our charity. And it leads again to the issue for me around the fact that you mentioned that there's still that vaccine hesitancy. And it does really concern me that we learned so much during the pandemic about the issues that were happening around the health inequalities of people dying more than others because of all sorts of reasons. But we're several years on and that's still happening. So I'm interested really as part of winter planning, yes, but longer term, what's being done to still work with those communities? You mentioned health champions, but it doesn't seem to be working. So what is being done to promote the use of vaccines and support communities to take up what's on offer and increase this uptake rate, which is clearly not where it needs to be.
So I think the planning from April was around the winter plan. We're um, we're doing vaccinations all year, so I think that we're continually planning for the vaccination program that's not started April, and also we have the spring summer vaccination program. So for all of those, we work closely with the local authority on the comms, and I'll bring in Viv also to talk about some of the work that we've been doing around engaging with the communities. And
thank you, and thank you, sir. A really valid question, because what we know is that vaccine uptake is not consistent across the patch, and we know that it's our most vulnerable communities that are less likely to take up the vaccine offer. So we within the public health team, we work very closely with our ICB colleagues to really understand the data and to understand where those pockets of populations are. So we know that our most deprived populations, for example, are less likely to have as good uptake as our most affluent populations. We know that there are particular ethnic groups that don't have as good uptake. But we also know there's particular groups in the population. So if we think about COVID and flu, we know that our under 65s have a much lower rate of uptake than our over 65s, and we've seen that quite consistently over the last few years, and that's something that's seen nationally as well. Another group that we're particularly keen to target is our pregnant women, because they are eligible for COVID vaccine and a range of other vaccines, and it protects them and their unborn child. And we know that vaccine hesitancy or low uptake is something, an area that we're really keen to work on. So as an example of that, the public health team know that we've seen particularly low uptake in our Polish communities in pregnancy. And they've done some targeted work around really engaging with that community to understand what are the barriers, and how can we overcome some of those barriers, and have them co-produce some materials and some approaches with that particular group to make sure that the information is in the right approach and the right language. And we've worked with the maternity services around that. So I suppose there's lots of examples around the work that we're doing. Would we like to do more, and will we continue to do more? Absolutely. I think it's a really valid point around how we're linking with our voluntary and community sector, because I think we can do more. And I think there's also things that we can think around in terms of how we're reaching out to our broader health and wellbeing board. So we're looking at how we produce more of a regular newsletter to share those communication toolkits and good news stories and things like that. So I think there's a range of approaches that are being delivered and will continue to be delivered, but it's just to give that assurance that public health works absolutely hand in hand in partnership with our ICB and broader system colleagues to do as much as we can to increase all vaccination uptake, not just our winter preparedness. Thank you.
Thank you for that, Viv. Thank you. Councillor Henry.
Yeah, thank you, Chair. I think Viv answered some of the questions I'm going to ask about. Basically, it was about the demographic variances in which the population have been vaccinated. We saw that in the COVID crisis, the COVID pandemic, where Pakistanis, Bangladeshis, and Black African Caribbean population were about 50% less likely to be vaccinated, more than the white population. Mm-hmm. So, what is a plan to address these variances, and particularly the cultural concerns that are surrounded around vaccines from these communities? Is something that we need to be able to educate people on. I think there's some issues there that we need to work on. Thank you.
I'm happy to come back on if I can.
Thanks, Viv.
Thank you. So again, really important questions here. So thank you for raising them. We now have a dedicated health protection team in public health, and which means we've got a little bit more capacity to do some of that really grassroots community engagement work. The team is still evolving, is the honest answer, and we're using a lot of the learning, as you've just articulated there, from the COVID pandemic, to how we take some of this learning and move it forward into our general vaccination approach and support moving forward. But I think we've got to acknowledge that some of the hesitancy that our communities are feeling is very deep rooted, and we need to support them to make informed decisions. So we have a range of practitioners out in our communities. They might be health and wellbeing champions, they might be local area coordinators, they might be community friendly knots, and a range of voluntary and community sector partners that we're working with. One, to understand those barriers, but also to then genuinely produce solutions together about how we might do that. If there are particular population groups that you're aware of in your communities that you're serving, that you're finding particular issues with, if you can let me know, then we can absolutely make sure that we're engaging with those specifically for you. But the way that we're using it is looking at the overall population data and seeing where we're finding those pockets of lower uptake and what population groups they are, so we can work very closely with those and the communities and organisations that work with them generally, so that we're building on the knowledge already in the system to do that.
Thank you, Bill. Councillor Duddy. Thanks, Chair. It's almost nostalgic hearing people talking about COVID, and it is.
Nostalgia, I think, is probably the problem.
But I remember that we were actually talking at that stage of, we had an army of people who came out to vaccinate people. We had an army of volunteers. We had an army of people working in the healthcare system that had never ever thought about doing it before. And I remember us talking about, could we harness that? Could we keep them involved? The health of the nation, and I suspect the world has just moved on, and I suspect we've lost that army of volunteers that we had back then, and that's where the nostalgia comes in. Not about all of the deaths or anything like that. I think we normally always talk about at this time of year staff vaccination. I didn't see anything about the staff vaccination in that. It could have been an omission, and there's often years when institutions and the hospitals take a pride in who has the highest number of staff being vaccinated, and that's true of the frontline staff, but increasingly important in the backline staff and the backroom staff. I didn't see that here this time around figure wise. I think again, the army of people doing the caring is as important as the people who are getting ill, and I think we shouldn't sort of lose sight of that and get it out there and promote it. But as I said, there was always a little bit of pride in that, Hazel. And I think I'm right in thinking that the opportunistic vaccination programme in the outpatients, etc., of Queen's got an award recently. I see it was certainly nominated for an award as one of the best interventions that's out there, and that's the type of innovation that keep people well this winter. So I was very pleased to see that. I thought that was great. I do think rather than vaccine hesitancy and vaccine deniers like we might have in America, it is truly an apathy. And I think it's an apathy born out of a degree of confusion, because we have an introduction now of a vaccine, RSV, respiratory syncytial virus, and it's between 75 and 79. And then you can get your flu vaccine, but you can't get it if you're not in that category at the same time as the RSV. And then you've got your COVID vaccination, and it's a coordination. I think we've confused people to the degree that they'll have the RSV and they'll think they've had the COVID, or they'll think they've had the flu. I think that's where comms can come in, Alex, and make sure that people understand. I think the more vaccines, the more confusion, and it is a true confusion of people who can't actually do that coordination. The great example of the apathy that exists within the vaccination world was highlighted earlier this year with some phenomenal outbreaks of measles killing children in the Midlands, etc., and ruining our reputation as being measles free for a number of years. And therefore this is just symptomatic of an apathetic population. I'm going to say that one of the things that was mentioned, I think I heard Councillor Henry or Councillor Henshaw mention it, is the winter fuel payments. and obviously that will have to be factored in somewhere. I think it's important on comms to move away a little bit from just vaccinations and concentrate on the fact that we are going to expect 30,000 excess deaths in winter this year, Chair. Those 30,000 people could go up to 60 or 70,000 if you had a bad flu, if you had a bad outbreak of COVID, etc. And this is an inevitability in the UK every single year. But it's not unpreventable. If you look at colder countries like Finland, Iceland, if you look at Norway, you look at other countries, they don't have that excess death rate. But every winter we come along, we get a cold snap and we get 30,000 people dying. I mean, in the first couple of days, the shock causes heart attacks and strokes. After that, people huddle together for warmth and the respiratory viruses spread amongst overcrowded houses. And then if it persists for long enough, people get hypothermia and die. We know how it happens, but we equally well know that it can be prevented. Now, obviously, keeping yourself warm, and Alex, we should be doing this through comms. So I don't think Alex has got his hearing aids in, but we should be doing this through comms. We should be keeping people warm. We should be having people with hats on. We should be having warm clothes and long johns, Councillor Jackson. We should be having people eating hot food. We should be having hot houses and warm houses, and that's where the winter fuel payment is actually gone. That may not be there. We should have insulation of houses, etc. So there's a variety of things that we should be doing and can do every year, which are just as important as vaccinations, and they're the responsibility of individuals and communications to say we can keep ourselves warm, we can feed ourselves, we can look after people living on their own as well as vaccinations. And I think it's a real shame that the hospitals will be full of people who get respiratory viruses just because they're huddled together to keep warm, etc. And we're not doing enough to prevent excess deaths, which other countries simply, the Director of Public Health will point out, much colder countries, countries with much greater climate challenges, but they don't have that level of debt that exists within that. So again, I think I'm going to come back to what Dave said. There is action out there, and for the first time in my living memory, and not something that I have any understanding, GP surgeries are capping lists to the number of people they will see. As a vocational GP, I don't believe that we should ever cap care, that we're there to provide a service for the person. We're not there to limit the service that we give to them. But there are a number of practices out there now that are saying we will have 25 consultations in the surgery for a doctor, and when we hit that level, we will not see anybody any further. This is throughout the country, and therefore there's a direct result. You will have messages that say, we are now full, we cannot see you, go to casualty, dial 111, go to your pharmacist, but the surgery is effectively closed. And this is a winter thing that will have a direct impact on people without any questions whatsoever. So I do think pharmacies, again, and you mentioned pharmacies, they're ill-equipped to deal with overflow. They haven't got the residual confidential facilities to actually deal with things that general practice can't deal with. We're asking them to do it, they're not funded to do it, and they don't have the estate to provide it properly. So we're concentrating a lot on COVID vaccines today, we're concentrating a lot on the winter pressures, but these are all year round pressures, and we should be preparing them all year round. And I do have the greatest of sympathy for the ICB, etc., because it really is generally an unwinnable battle. But you do your best.
Yeah. Thank you, Dr. Lee. I don't know whether there's quite a question there, but I know that, your assessment on things, it's disappointment that that GPs now are doing 25 appointments a day. No, it's a sad reflection on where we are today. But I kind of saw, I do wear my long johns when I'm feeling around in the morning. Being a farmer, I have to do that. Go on. Councillor Bailey, please.
Thank you, Chair. Honestly, a lot of comments have already been made about the vaccination process. So the first thing I'd possibly say is that one of the things that I picked up, when you're speaking to residents and whatnot, is one person said to me, "Oh, they've had they've had every single COVID vaccine, but they're giving it a miss this year because they keep getting sick, and every time they go for a COVID jab, it just gets worse." I suppose some of I know Councillor Anderson mentioned about vaccine fatigue. In some ways, I think this is a reflection. I think some of the reasons people aren't taking vaccines nowadays are perhaps different from 2021 and 2022 when the vaccine process was in full swing. So I definitely think it's worth us, having another look and actually, understanding some of the reasons why people are now not having vaccines. It might be slightly different to why they weren't in the past. And the other comment I'd possibly add as well is possibly more for public health actually. I know Sarah from Healthwatch mentioned about our CVS services and how how helpful they are actually of getting to some of our communities. I know in Basel, for example, we have a strong Polish community, and actually when the Home for Ukrainian scheme came in, a lot of translation was done through that service, and a guide was actually produced. So I don't know if public health are going to pick up on some of these outreach programs, but it's definitely worth reaching out to, at the very least, the Basel or BCVS. About what they're doing to get into some of our harder to reach communities. So that's what I'd like to add. Thank you, Chair. Not really a question in there, but
Would you like to make a comment or Viv? Yeah.
Yeah, thank you, Councillor Bailey. Really helpful comments. We can certainly feed that back into the team in terms of some of those specific contacts in Bassett Law, and I think the offer is out there to all members in terms of if you have particular really effective and well embedded community and voluntary sector organisations that are reaching communities that we may not be reaching the way that we need, then please do let us know and give us the contact so we can try and utilise those and increase our uptake overall. But thank you.
Thank you, Viv. Councillor Lee.
It's a question for the council, just on vaccinations. Do we have a free rollout to all our own staff members?
So I'll take that one if I may, Chair. Thank you. So we have a county council vaccination programme for all frontline staff. So it's not for all staff; it's for staff that are providing that frontline health and social care. That programme has just finished. We've had 61 clinics over 39 venues this year. We've vaccinated about 1,358 people so far. There's also a voucher scheme that runs alongside that. So if the clinics aren't convenient for those members of staff, they can get a voucher to go to a local pharmacy for that. And we haven't got the figures for that yet, is the honest answer. Now, we know that uptake this year is slightly higher than last year at 37.2% so far. Last year it was 36.2%. So we're going in the right direction, but there's still a lot of staff that we would like to engage and vaccinate, because we know that if we can protect them, then we can also protect the vulnerable people that they are serving and working with. So yes, there's a comprehensive offer, but there's more that we could do, and that we are constantly trying more and more every year to increase that uptake with our staff. But again, it's a voluntary thing. We cannot make staff have that, but we would strongly encourage them, and that offer is still open to all staff if they would like to get a vaccine, if they're frontline, to be able to have those COVID and vaccine.
Just to come back, Chairman, I get that. I don't understand the flu. I'm not medical trained, so this is a stupid question. I apologise. But is it not possible, saying I had the vaccine, but I could then spread it to other people? And if that is the case, then should we not be offering it out to all staff members? Because at the end of the day, we know that if one person is off, it affects what we can do here, because it's not just frontline people. We've got people that answer the telephones, people that do the casework, people that put things into the computer. If one department goes down, we could have lost a major thing that we do at the council. I get it's about not spreading it as well, but we need to make sure that when people ring us or get in contact with us, our staff are here. And also, it will cost us money, right? If somebody goes off and we have to replace them for a temporary period of time, it costs us money. So would it not make sense rolling it out to every staff member here?
So if I may come back on that, Chair. So we have considered that in the past, what we're trying to think around is how can we utilise the money that we've got in the best way possible. The reason why we prioritise those frontline staff is because yes, they have got the protective element for themselves, but it's more about them protecting themselves so they don't get it, so they don't pass it on to those vulnerable people. So you know, if and there are national guidelines around where it is the most effective, which population groups are the most effective to give the flu and the COVID vaccine, which is why you see that we don't have that available for everybody. Now, if we could and people would like to have that, then that would be an individual decision for the individual to weigh up whether that was right for them. And there would be some elements in terms of staff sickness. We have seen that in other areas in terms of staff going off with these illnesses, which can, you know, make people feel very poorly and in some circumstances make them very poorly. But we have to prioritise where we can have the biggest impact, and the biggest impact is with our frontline staff, which is why we're prioritising that. By all means, we can go back and have a look at that. But if you look at the national evidence, it is about that frontline staff of group where you will get the biggest impact on our population.
Councillor Henshaw.
Come back. I'm very interested in the point you made in relation to people saying that they're not bothered about going for a vaccination this time because it makes them ill. I mean, there's a lot of misinformation and untruths about this sort of thing in relation to. I mean, years ago when they used to have a live vaccine for flu, you know, in when Adam were a lad, should I say, you know, people used to say, "I'm not going for the flu jab because it gives me flu," you know, and now it's we've got. I think we've got to challenge the opinion that the untruths and the misinformation, and I don't know how you can do that as a department, but I think it's something that we've got to consider challenging.
No, I totally agree. I think that's one of the main things that's come out of this discussion actually is about the vaccination and the uptake of the vaccination, and not persuading people, but explaining to people the benefits and not the negatives, more about the positives. And I don't know quite how we go about doing that. As I don't know how we've learned over the years, past years, to encourage more people to take it up, especially frontline staff, because that's important, though, that we we keep people fit well over the Christmas period. Sorry.
Yeah. So we've got a very active programme with colleagues in public health and local authority partners and other partners in the local health and care system about how we can do this better. We have taken all the learning from COVID, and we do learn each year. I think your point around, Sarah, about how we engage with and do engage enough and listen enough to the third and voluntary sector, I think it's a valid point. We can go back and do that. I think it would be interesting to have a debrief after this flu and COVID season about, from your perspective, did we do as much as we could have done? What have we learned, and how might we reflect that in next year's campaign? Because this is an ongoing annual process which we need to lead from. From my perspective, the relationships in the system and the work that we do with the local authority colleagues and other colleagues in the system is actually really good, better than many of the systems I've been in. So we're actually well placed to do that learning, and we clearly want to be as good as we can and recognise the beneficial effects, not only for patients receiving the vaccines, but for the general population in terms of further spread. So it's great input, and we'll take as much as we can away from today. And I think coming back to see what we've learned and what we do differently, I think will be a helpful and useful thing for us to reflect on.
Thank you, Viv. Do you want to come in?
Thank you. I think Dave covered a lot of my points there. I think we know in terms of the national evidence, they talk about the 3 C's, so confidence in the vaccine and the efficacy, or how safe it is and how effective it is, how convenient it is to go and get the vaccine. And then there is something around how complacent people are, so whether people think it's important for them. And I think there's a lot more that we can do in terms of really understanding for different groups in our population, the different factors are more important, and the underlying thoughts around why they decided this year they're not going to have it when last year they did. Those are the sort of things that we want to really start to unpick. And as Dave said, we will work collectively around that to understand those things, and then think around how we do have that equitable approach, building on some of the mobile resources and things that we've got, but also making sure we've got that offer that's really broad to our population to do the best that we can, and just keep raising our ambition and trying to get our uptake up every year. Thank you.
Yes, thank you. And it's not helpful. The messages are coming out from America at the moment, aren't they? So unfortunately, Councillor Adams.
Thank you. Yeah, I just want to go talk a little bit about the side effects side of it for a second, because obviously there are side effects that do affect some people in vaccines. We all accept that. I wonder if some of the I do know somebody specifically that had the COVID vaccine and was immediately ill after it. Now I don't know if you can, it's like taking your car to have a fuel change and then your tyres go flat. I don't know if it's always related directly to that moment in time or that intervention, but in this case a vaccine, is it directly related that they then become ill? And for that person, it actually it was very difficult. And I just wonder if some of that negative view maybe comes from the fact that we don't deal with those things head on, and in fact we sometimes come out with such a positive message about how they can benefit the public that when they hear something that is negative, if we're not dealing with that head on and maybe explaining the reasons for that, are they then taking 2 points of view, one real, as in for them somebody they know, let's say like a relative or something like that, or a friend, and then at the same time we're dealing with effectively the health provider that's saying something else, and how do we marry those two? So is that a case of we're not dealing with the fact that there are some negative effects in some cases and talking about that publicly, and that's maybe having that negative impact on those people that are making that secondary decision not to have it? And I also think as well there's a case, the strength of the actual virus, as my understanding, is also because as I understand how viruses work, they spread, they break, they become less and less dangerous. I believe that's right. So again, it's because people aren't feeling the effects of it in the original way they felt the effects of it. We're now dealing with, again, another reason why people maybe aren't taking it. So I just wonder if because we're instead saying everything's fine, everything's great, if we're doing that instead of maybe saying, well, actually, look, we have everything is in 85, 90%, whatever. I don't know what the numbers are. Everything is fine, but in some cases, these things do happen, and these are the reasons why. I just wonder if maybe it's an information overload in one area, i.e., the positive impacts on population and themselves, and less, and because we're not talking about maybe as much. It's creating a vacuum in the availability for alternative voices that maybe have other motivations, let's say, to bring a voice to that. So that's it. Thanks.
Thank you.
So there's a really valid point about describing the benefits and the risks of the different vaccines, and that being an ongoing learning process. And it's something that came up quite recently with some concerns around the COVID vaccine that we had. And I think that some of the learning from there is that we're going to work, there's going to be some conversation in the national team about what that looks like in terms of a national conversation around vaccination. On the whole, vaccinations are remarkably safe. It's one of the safest things that we can do. There's no doubt that some people have a sore arm because of an immune reaction, and there's no doubt that some people have a larger immune reaction, which is remarkably uncommon, but still there. With any sort of medical intervention, there's a large perceived impact on health, placebo effect, and that is actually more significant for individuals than actually the measurable impact once you go out for that. So some people do actually feel ill, even though they feel ill if that was water that was injected or the vaccine. So I think points around being able to be clearly talking about that it's not all positive is absolutely reasonable. I think we should look at that as part of the flu campaign next year. But the levels of safety around the vaccinations are remarkably high, and the level of safety around the COVID vaccination is significantly greater now than it was when the COVID vaccination was first introduced. And I think that's talked about quite as much as perhaps it could have been, in that the new vaccine doesn't have half the problems that the original ones did. So point taken, we'll feed that back as part of our national learning programme around vaccinations.
Thank you for that, Dave. Thank you. Quick one, John.
Just a very quick one. There's no doubt that during COVID, Jonathan Gribben was on the TV quite a lot, every day you had a news insemination of the population with regards to the health of the nation, with regards to get out and get your COVID vaccination, be part of the community. What we're missing at the moment is the equivalent of a Martin Lewis with the money program. He's out there telling you how to invest your money. We need somebody out there, the health of the nation, and again, we need somebody broadcasting that with a charisma that can actually bring people with them. We need an NHS Martin Lewis, and we just don't. We just don't have one at the moment. Every day out there, and people tuning in, especially to say, "I wonder what Dave Briggs is going to say today." And it's a simple thing, but be under no illusion. These things work, and people listen to them, and we just don't have that charisma. We don't have that person. We don't have that dissemination of information. And I'm going to get Councillor Lee to recommend that it gets put onto the recommendations and add it on to the end of it and change the whole ethos. Okay, there we are, Dave. There we are, Dave.
Thank you, Councillor Dolly. I'm sure you're the right man for the job, to be honest. But, yeah.
So we recognise that it's important to get our message across around vaccination, and we have offered. I personally was always prepared to speak on the various forms of media around the effectiveness and usefulness of vaccines. Can't guarantee it'll be charismatic, however. And depending on the news, depends on the uptake. I think if we start getting stories around high levels of flu, the offer and the quite assertive offer of media input will be taken up. Unfortunately, it hasn't been taken up above this time. However, there has been certain stories run in the print and media. We have got a very novel media campaign that's jointly done with Alex's and the local authority team, specifically around vaccination. And I think maybe not come across as clear in the paper, but there's all sorts of techniques and things used for this and the winter plan to make sure that we're not wholly and solely reliant on the more national mainstream media. And I think that's going to become increasingly more important with our younger or more IT literate people. And I'm certainly fascinated by the work, and that might be something we can share outside the meeting about those techniques and skills.
Thank you, David. Thank you. Thank you, members. That's been a really good discussion, and a lot of views been put forward. I mean, it's been obvious that the uptake of the vaccine is a very important, vital role, that a message we need to get across, and really it's a national role, isn't it? It's not just Nottinghamshire; it's a whole national role, and probably something we ought to be doing on a wider basis. Especially there's certain groups and ethnic groups that are difficult to persuade or contact or to do this, and I think we really it's important that we do this going forward. We'll move on to the recommendations, and it is for the report to be noted that the second part is that a further update regarding the review of the 24-25 winter plan be considered this summer, which I think we've come back a little bit. I know we probably won't know the results of the uptake if I have this meeting a little bit earlier, but we will know what happened last year and what lessons can be learned, and how we can improve the uptake. If we can say it's down a little bit this year, going forward, what we need to do, as Councillor Dolly said, do we need a charismatic frontline man there selling it? Yeah, which is probably right. Because the power of the media, the power of social media is very strong. Probably not using it enough, So. Yeah. Anyway,
wake her up from where she is.
Do you agree with note recommendations? In favour. Thank you very much indeed. Thank you, and thank you, Dave, Gemma, and Hazel for coming on for this. Very, very again lively debate. Hope you're taking on the views on board, and we look forward to seeing you next year. Thank you. Thank you.
Yes. We'll have to do a TikTok, Dave. Just something like that. Chair, I need to leave, I'm afraid, but can you take on board what I said about the GP contract?
We're doing the works programme now. It would take 2 minutes to council car. So, a few matters to highlight in respect to the work programme. We're currently going to arrange a site visit to the new A&E facility and to the National Rehabilitations at Stamford Hall. That's on the back of what John was asking for prostate. Yeah, prostate. Please note that the next meeting is on the 7th of January. Members will consider a report based on impact assessment regarding the ICB's proposed sustainability measures, which was requested at the October meeting. I mean, it was important that we go for that. As always, if members become aware of potential items that are in keeping with the health scrutiny priorities to be considered as potential items for the work programme, I invite you to make representations. So, Councillor Carr will take yours on board and consider it for the work programme going forward. Okay.
Councillor Jackson, can I come back to the point I made last health scrutiny meeting, in that, yes, we have a sporadic contribution from people when something comes to their mind that it might be interesting to put on a work programme, but it's certainly not a strategic approach to the challenges of the provision of an adequate health scrutiny to the people of Nottinghamshire. I think that we have no doubt that Catherine obviously feels that she liaises sometimes with Health Watch, who may sometimes have their pulse on the problems that exist, but it's only a small feeling of the pulse, as not listening to the health of the patient as a whole. So I think that we need to convene a group with the sole objective to brainstorming the areas which over the years have been neglected, be that the amputees such as Councillor Lee, who have widely put forward ideas in the past which have been sort of lost on the desert air. And I think that as a combined group, we have the wide community experience to be able to sit down and work between us in a genuine, perhaps we need a workshop, Councillor Jackson. Health scrutiny needs, like Health and Wellbeing Board, a workshop. I am hereby recommending that we convene a health scrutiny workshop with a goal to reviewing our health scrutiny approach. And I'm actually going to put that forward as a motion. Will anybody second me on a health scrutiny workshop? All yes. Those, we've got a seconder here. Can we put it to the vote, Councillor Jackson?
No.
We have to come on to recommendation.
Councillor, we knew that you wanted this, and we took advice on this. I mean, Catherine is going to...
A workshop, Catherine. You wouldn't have taken advice on that because I hadn't even mentioned it, unless you're some sort of clairvoyant. I wouldn't say that's not within your skills, Catherine.
So it sounds like a suggestion to have a work programming event, and I think that's something that we do, and it's great practice. I think we can definitely look at scheduling something like that.
An away day.
Well, I can't promise an away day, Councillor Dottie.
Coffee and biscuits.
But I can tell you that I will certainly look into scheduling a conversation with the chair and vice chair's agreement.
Yeah. Done.
Done. Yes. It's something that we can absolutely do. And we will do, just to let you know, we will be doing lots of those kinds of things, especially looking into the next year, as we'll be, very soon coming up on those sort of early conversations about the next year's work program. What are the priorities for next year, setting the tone there. And so those conversations are definitely something we're going to be scheduling as part of that. I'm glad.
The work programme is always a living document because it's always changing. There's always things coming up. Sarah, do you want to come in?
Yes, thank you. I feel incredibly privileged to be invited to this meeting. I'm not a committee member, so I don't get to vote, but I think it's really excellent that Health Watch is enabled to be in these meetings and contribute. With that in mind, one of the key things that we would really like to propose formally to this committee is that whenever we do one of our reports, and there's been numerous reports that members have mentioned in Health Scrutiny that we've made, with recommendations that we've made on a number of issues throughout the last few years. We've been going 11 years now. And when we do make those recommendations, one of the key problems we've got with the way that Healthwatch was set up is that we're not like the CQC. We can't put sanctions on anybody. We can make recommendations. However, what we would like to be able to do is to bring our recommendations and to send reports to you as Scrutiny so that you see our reports directly, and any recommendations that we make when we come to these meetings to be able to highlight those in any other business, so that this committee could maybe adopt some of those recommendations in order to put some weight behind what Healthwatch is saying. I mean, one of the key issues that's happened this last year was the investigation we did into Notts Healthcare Trust. That was before the CQC went in. Our report was actually mentioned by the Secretary of State. We've made a number of recommendations to the Healthcare Trust. They're being enacted at the minute, and we've got a great working relationship with them, and things are moving. Where we might make recommendations where services may not wish to move as quickly as we'd like them to, often a nudge from Scrutiny can be something that is really positive. So I just wanted to raise that with you, Chair, as a new chair that I'm meeting for the first time, but also to sort of bring that to your attention that we do make numbers of, but we can spend months chasing up service providers to tell us what they're doing on those recommendations. Whereas I think if we worked in partnership with yourselves and Scrutiny in the city, because we're recommending the same thing there, we can then
send them to somebody at the moment in the county council.
At the moment, there isn't somebody that we've said, oh, we'll send our reports out to. And that was one of the things we met with some of you earlier this year to tell everybody what Healthwatch was about. But making those formal arrangements for how we make sure reports are sent to you, that you get them. We've got Health and Wellbeing Board with the new newsletter, which we can do through those. But I think Scrutiny is a really specific relationship between Healthwatch, the voice of patients and the users of social care, and yourselves, and how can we formalise that a little bit better so that you get the information that we've got for you, and then we can work together on highlighting some of the issues that have happened over the years. I mentioned to Catherine earlier, we made some of the first inroads into NUH maternity services long before anybody else did, and yet very little of what we put forward to the Trust at that time was taken up. If we'd have had a more formal relationship with Scrutiny, we might have actually got to the bottom of some of those issues a lot quicker. So that's the sort of thing that we don't want to leave, to be in any position where we have something that happens on all our watch that we could all work together harder on to try and tackle before it gets too big.
Thank you, Sarah, and thank you for coming along and contributing to the meeting, and we'll have a chat afterwards about things. Thank you very much. Councillor Reddy.
Sorry, just to add, definitely do the mail shot. We'll get the information out through the new chairman's report that we're setting up. But at Health Wellbeing Board last time, pharmacies came up, and I know we've got it on the February meeting, but they were looking at, correct me if I'm wrong, Viv, access to the drugs through the pharmacies, but also access to pharmacies. I don't know if that can be included in that, because I don't think at the moment it would include that unless it was a specific ask.
We'll look into that. Thank you. Thank you. Okay, I move the recommendations on the work programme. All in favour of that, for noting. Thank you very much. Thank you very much, members, for a really good meeting today. Very good debate. Yeah, very open. I think a lot of points and view were taken on board by the ICB. So thank you very much for everybody for contributing.
Oh, yes, you got to catch him, haven't you? Well then, like,
he's like that, is he?